Pre-reading tasks. Exercise 1. Check the pronunciation of the following words: uterine fibroid embolization, menorrhagia, dysmenorrhea, dyspareunia, hysterectomy, leiomyomas, hyaline necrosis. Myomectomy, submucosal, benign, intramural, devascularize, fluoroscopic imaging, aortic bifurcation. Exercise 2. Explain the given above concepts in English. Uterine fibroids are among the most common tumors of the female reproductive tract that occur in premenopausal women. Although uterine fibroids are benign, they can cause considerable symptoms. The most frequent symptom is menorrhagia, with iron deficiency anemia often occurring as a result. Dysmenorrhea, pelvic pain and pressure, dyspareunia, urinary frequency and urgency, and other pelvic symptoms may occur. Symptoms are often of sufficient severity to necessitate surgical intervention. Fibroids are the most common indication for hysterectomy in the United States. Exercise 1. Answer the following questions. 1. What are the symptoms of uterine fibroids? The most frequent symptom is menorrhagia, with iron deficiency anemia often occurring as a result. Dysmenorrhea, pelvic pain and pressure, dyspareunia, urinary frequency and urgency, and other pelvic symptoms may occur. 2. What factors are responsible for initiating fibroids? It is not known what initiates fibroid genesis, although it is clear that the growth of fibroids is affected by the presence of estrogen, progesterone, and a variety of growth factors. A role for gonadal steroid is suggested by the fact that fibroids are not seen in children and tend to regress after menopause. 3. What abnormal changes occur in the woman body affected by fibroids? As they grow, fibroids cause enlargement of the uterus. Fibroids that are located in a submucosal position, as well as intramural fibroids that abut the endometrial lining, are associated with heavy menstrual bleeding, whereas the presence of large fibroids or the overall enlargement of the uterus is associated with local pressure, pain, or compressive effect. 4. Is this disease curable? Yes. The treated fibroids shrink over the course of several months to years. As a result, symptoms associated with the presence and growth of the fibroids is reduced. 5. What treatments are possible in the case of fibroids? What does the choice depend on? Medical therapy, acetaminophen and nonsteroid anti-inflammatory drugs, NSAIDs, are often effective for the relief of pain associated with fibroids, although these drugs do not reduce bleeding. A variety of hormonal therapies, including androgenic steroids, mifepristone, and gonadotropin-releasing hormone agonists and antagonists, have been shown to reduce uterine volume and bleeding. For patients requiring interventional treatment, the principal current options include hysterectomy, myomectomy, endometrial ablation, when menorrhagia is the primary indication and endometrial anatomy is appropriate, and uterine fibroid embolization. 6. What therapy is considered to be a reasonable option for most patients? Uterine fibroid embolization is a reasonable option for most patients in whom intervention is considered to be appropriate. 7. Are there any contraindications against uterine fibroid embolization? Pregnancy, suspected pelvic cancer, active infection, or indeterminate endometrial or adnexal abnormalities requiring further evaluation and clear contraindications. All these are contraindications to surgery. 8. What kind of examinations and tests are needed to be performed prior to undergoing uterine fibroid embolization? All women should undergo a thorough gynecologic evaluation and pelvic examination before the procedure. In addition, imaging of the uterus by ultrasonography or MRI is necessary to evaluate the size, location, and number of fibroids. Laboratory tests that are performed before the procedure typically include a complete blood count, coagulation studies, and metabolic panel, and a pregnancy test. 9. Could you describe the procedure of uterine fibroid embolization? The procedure is a percutaneous angiographic technique performed in a radiographic suite with the use of video fluoroscopic imaging. The patient is usually sedated during the procedure. A small-bore primary angiographic catheter is inserted into the common femoral artery and is advanced with the use of a guide wire over the aortic bifurcation and into the opposite hypogastric artery. The primary catheter or a smaller bore microcatheter placed through the primarily catheter is then advanced into the uterine artery and typically placed in the distal transverse artery. An arteriogram is obtained to visualize the anatomy of the arterial plexus supplying the fibroid. Embolization is then performed with the use of particulate embolization material. The embolic material is injected and is carried by the arterial blood flow to the vessels feeding the fibroid. These vessels are preferentially occluded since they are larger and have a higher flow than normal myometrial branches. The procedure is terminated when the fibroid blood supply is occluded but there is still sluggish flow in the uterine artery. The catheter is then moved to the ipsilateral hypogastric artery. And the procedure is repeated in the opposite uterine artery. 10. How does a woman feel after this procedure? For several hours after the procedure, most patients have moderate to intense pelvic pain that requires treatment with intravenous narcotics and NSAIDs. Patients also typically have malaise, fatigue, and myalgias for several days. About a third of patients have a mild fever, with only 2% having a temperature of more than 38.5 degrees Celsius. Most patients return to work and other normal activities within 7 to 14 days after the procedure. Exercise 2. What do you know about interventional procedures mentioned in the text? Find out the information about them. What are their advantages and disadvantages compared with uterine fibroid embolization? Exercise 3. Here is the case history of a woman suffering from uterine fibroids. Insert the given verbs in the text using them in the right grammar form. Discuss, worsen, reveal, note, have, increase. Undergo, refer, confirm, order, show, recommend, suggest, be, present. A 45-year-old, premenopausal woman, with a history of one spontaneous abortion, presented with menorrhagia and dysmenorrhea that had been progressively worsening over a period of 10 years. She does not wish to have any more children. On physical examination, she has a firm, non-tender, enlarged uterus. The ovaries are not palpable. Laboratory tests in the past revealed intermittent mild anemia that was correctable with iron supplementation, but more severe anemia has been recently confirmed. And she has been having increasing difficulty managing her menstrual bleeding. In-office ultrasound examinations have shown several intramural uterine masses consistent with uterine fibroids that have been slowly increasing in size. The largest measures 6.5 centimeters at the point of its greatest dimension. The adnexa are normal. The patient's gynecologist ordered a hysterectomy. However, the patient does not want to have a hysterectomy, and her gynecologist recommended uterine fibroid embolization as an alternative. She was referred to an interventional radiologist who suggested a magnetic resonance imaging (MRI) scan. The results of the MRI confirmed the ultrasound findings and ruled out adenomyosis. The interventional radiologist discussed with the patient uterine fibroid embolization as an alternative to hysterectomy. Exercise 4. What are the patient's complaints? What treatment should be recommended for this patient? Can you justify your choice? Insert the required adjectives using the appropriate prepositions, if necessary: appropriate, invasive, acceptable, sustained, rapid, fewer, referable, conservative. Subsequent, hormonal, interested. Conclusions and recommendations. The patient described has symptoms that are clearly referable to her fibroids, and the fibroids are anatomically amenable to treatment with embolization. She does not have any contraindications to the procedure. She is not interested in having more children and is seeking a less invasive treatment than hysterectomy. Since her symptoms have been steadily worsening for 10 years, it is unlikely that hormonal therapy will be acceptable to her. Conservative therapies cannot provide sustained benefit. In selecting between hysterectomy and embolization, the patient should be told that recovery is more rapid and early complications are fewer with embolization, but that she has approximately a 20 to 25% chance of requiring subsequent invasive intervention. For this patient, who would like to avoid hysterectomy, uterine fibroid embolization would be an appropriate choice.